Fertility Factor Fiction, our show on the web every week where we share the latest and greatest in infertility and try and educate everybody to make their cycles more effective and hopefully cheaper. We have a phenomenal topic tonight on the infertility world, looking at the importance of the morphology of an embryo and the age of the embryo.
That doesn't sound good at all.
Are we good? Okay. So we're going to be talking about, sorry about the sound glitch, guys. We're going to be talking about the importance of your age and the morphology of your embryo, even when the embryo is euploid, meaning genetically normal. And that is a very critical topic because no one's actually looked at that before. And so this is a bit of a game changer for us. So very interesting stuff, hopefully groundbreaking, and hopefully you guys will get the information that you need. We still have a lot of feedback.
Let's go ahead and talk more.
Okay. But we don't have a mic now, do we?
Still have a mic, don't we?
We're good? Okay, so just trying to get some sound glitches worked out here. Sorry, guys. So the title of the article is, and you can pull this up if you want, it's called The Impact of Euploid Blastocyst Morphology and Maternal Age on Pregnancy and Neonatal Outcomes in Natural Cycle Frozen Embryo Transfers. So the interesting thing here is that they kind of targeted a very specific group of people. These were all people getting natural cycle frozen embryo transfers. They all had euploid blastocysts, and then they broke it down by the morphology score and the age of the patients and looked at both the actual, were they pregnant and did they have a live birth outcomes, as well as what were the neonatal outcomes, miscarriage and so on. So interesting study. It's out of Stanford, which is quite interesting, useful information and data. And so good study group, well-known people, good data set as well. The reason this is important is because we frequently focus on, are the embryos normal or are they not normal? And we've always been told that if you have a normal embryo, that the age is not relevant. So the question really was, is the age relevant in this study? And then as well, sometimes we kind of pay less attention to the morphology score on the embryos when we're looking at euploid embryos where they're genetically normal. But this study is saying, is that important still or not? Is it not important to look at the morphology? So let's just briefly talk about morphology scoring. So most morphology scoring systems are scoring systems used to describe what the appearance of your embryo is under the microscope when they're getting ready to freeze it or use it. And so that score has a number associated with it, which is the degree of expansion of the inner portion of the embryo leading up to hatching and then fully hatched. That goes from typically 1 to 6. And then there's a letter grade given to the inner cell mass, which is the part that becomes your baby. And that usually goes from A to D. And then there's a letter grade given to the part that's the trophectoderm, which is the part that becomes the placenta. And that also goes from A to D. So we've reviewed the importance of your morphology score in general when you're doing frozen embryo transfers and what embryos you should have when you're freezing them and what embryos you want coming out of the thaw. And generally speaking, you want kind of like a 4AA or a 5AA going in and out of thaws, because that's going to give you your best result. Something like a 2DD would be a disaster embryo. So the higher the number, the more expanded it is, the more vigorous the embryo is potentially. And then the letter grades have always denoted the amount of granulation or degradation that there is in the various cellular components of the embryos. So what these guys did was they took 610 patients from June 2016 to June 2020. So a long period of time while they were studying these groups. These are all people that had natural cycle frozen embryo transfers, so they weren't being medicated or anything. And they broke them down into 5 groups. So you had AA embryos, AB embryos, BB, and then BA, and then you had C, where they lumped any kind of C together. So whether it was CA or CB or CC or CD, or conversely, AC, BC, CC, or DC. And so they grouped anything with a C as one large group. Everything else was separated out into different categories. So I'll flip to the next page and we can show you kind of what they did here. So one thing about this study, it is retrospective. So they were looking back at their data set. This was not a prospective study, which is more valid and more valuable. Their basic technique was the same amongst everybody. So not a huge difference in what they did. They accepted an endometrial thickness for transfer that was at least 7 millimeters. And the only time they made exceptions was if you had previously had a thinner lining, but it was okay. You want it bigger? If you previously had a thinner lining, but still did well. Okay, so we're going to go look at the data because that's the important part here. And I want to kind of show you all of this. So here's your clinical data set. Average age, fairly similar across the different groups. A little bit of a trend towards increasing, but not statistically significant. So on average, these people were like 35, 36, 37 years of age, same roughly for their age of retrieval. The vast majority of patients had previously had an embryo transfer, so these were not necessarily patients that were doing it for their first time. That's important to remember. And interestingly, especially for a US population, the majority of them had a very normal body mass index, so 25. And you can see that if I highlight it for you right here, it's the maternal BMI. So just above that line, you can see where everybody is 25, 25, 23, and so on. So most of them were not smokers. Only about 5% or less of the population were smoking. Reasonable mix of ethnicities and racial backgrounds, the majority being white. And then the infertility diagnosis mixed across the board as well. So nothing really special there. Okay, so what did they find when they looked at all of this data? That's the most important stuff you guys want to look at. So when they analyzed this in terms of comparison of pregnancy outcomes among different euploid blastocysts, you can see that the group that had AA quality embryos was 197 patients. 67.5% of them achieved a clinical pregnancy, meaning a heartbeat. Only 3.6% had a miscarriage, 1.5% had an ectopic, and then live birth was 64.5%. So if you have an AA graded embryo, you have a very, very high chance in this study of ending up with a live birth. When they moved into AB, it's still very, very robust, if anything, even higher, 66.9% had a live birth. Miscarriage rates were basically the same. When you move into a BA, your rate's dropping a little bit to 55.6. And when you got out to BB, it was 56.5. And then when you get out to C, you get this huge drop down to 40.8%. The pregnancy outcomes were basically the same, nothing very significantly different. A little bit of a higher trend towards cesarean sections with the higher quality embryos and the lower quality embryos. In the middle, they're all kind of around the same rate. Interestingly, the group with the highest preterm delivery was actually in the highest grade embryos, the AAs. I don't think anyone has an explanation for that. So when you look at this in terms of actual risk calculations, if you look right here on table 3, this is where the meat of this study actually is. So I'm going to draw your attention to the reference grades because that's really important. So you'll see here what's saying the adjusted odds ratio. That's the number kind of under reference. And then you see here, I'm going to highlight it kind of with red. It says inner cell mass grade A. So they were referencing your chances of success compared to people that had an A grade for the inner cell mass, which is the part that's becoming the baby. So if you're a B, there was no statistically significant difference. So if your embryo is an A or a B, they got the same outcome because the confidence intervals crossed 1 and the p-value is not less than 0.05. So that means if you have an A grade embryo or you have a B grade embryo, you're doing great. You're going to get a really good outcome from that. But if you had a C grade embryo, which you can see down here in this column that's being highlighted now, there is a 67% drop in your success rate. And this is adjusting for all the confounding variables, including age. You see this huge degradation in success if there's a C in any part of the embryo. If you look at it with regards to the trophectoderm, again, if you're comparing to a trophectoderm grade A grade B trophectoderm, the placental portion, no difference. It's statistically the same. But when you skip to a C grade trophectoderm, it's again no difference. So the trophectoderm part does not seem to have as much of a relevance as the inner cell mass does. So in other words, you can have a not great placental portion to your embryo and still expect a very good outcome, but you cannot have a degraded inner cell mass portion, the baby portion of the embryo, and expect the same outcome. So this is really important because no one's looked at this before, and this is very new data for us when you're looking at genetically normal embryos. When you looked at age at transfer, that again was really important. So if you're referencing age 35 as the reference group, all these categories were quite important. So compared to age 35 and less, the group that's 35 to 39 has a 47% decrease in success. So even if you've controlled for the same quality of the embryo, if your age is between 35 to 39, you're going to see a big decrease in success with a genetically normal embryo compared to patients that are less than 35. If you go to 40 and over 40, you're seeing a 46% decrease. That's what that 0.54 means. You're getting a 46% decrease, again, highly statistically significant, demonstrating that when your age goes up, you are seeing a significant decline in success. The good news, it's not any lower than it is if you're 35 to 39, but the bad news, this is a huge difference compared to the rates that you're seeing for women that are less than 35. Now, all of this was for people looking at clinical pregnancy rate. When you increase this to the live birth rate, the numbers get even more significant. So I'll just kind of briefly highlight them in yellow for you. Your inner cell mass score is 68% less. When you have a C, the B cell is still not significant, although it was getting close. So they're still showing that a B grade or an A grade are the same, but a C grade is a huge decrease in success. When they looked at the trophectoderm, it didn't make a difference again for live birth, so that's really great. When they looked at age at transfer, again, you can see that 35 to 39, you're getting a 46% decrease. But now when you're over age 40 and you're looking at live birth, it's a 52% decrease for live birth compared to the clinical pregnancy rates we were looking at before. So the summary of all this is super important, and we can cut out of the image there, because what we're seeing now is new data that has never been shown before. And these guys really deserve a lot of applause for this study, because they have shown that even if you produce a genetically normal embryo, your chance of success varies depending on the quality of that embryo from its morphological score, and it depends on your age. And no one has shown that yet before. And this really helps us guide patients in our discussions, because if you've seen our embryo math video, you know that it can take quite a number of embryos to succeed. And this actually changes that math because it actually can make it even higher numbers to succeed when you're dealing with getting those genetically normal embryos, because that's what we're looking at, especially when age is a factor. So as far as a factor of fiction that age and morphology count when you have a genetically normal embryo, they count, and not just count, but they count a huge factor or a huge amount in this, because you're looking at rates that can be 68, 52% decreased compared to normal or compared to a reference range. And that's very significant for advising patients about what to anticipate. So I hope you've learned something from that. And I'm sure you guys all have lots of questions, so we'll take your questions now. And Tarek can start the whole thing.
Question related to the talk today. Did the data show significantly more female babies born in all groups, or did I not see? Oh, too many questions came in just now. Hold on. Or did I not just see that right? Any reasons for that?
Here's the data on babies that are female. You can pop that up. A lot more of the babies were female than male. So the numbers are skewed there. Or sorry, a lot more of the babies are male than female. So it's kind of hard to see it because they've got it misaligned. So I'll just kind of point that out to you because I'll need to do it with like this. So this goes to here and that goes to there. So a lot more of the babies are male than female in the AA category. A lot more of the babies were female than male in the AB category, more male. It goes up and down, back and forth kind of between the different categories you can see there. So in this one, it's female predominant. In this one, it's male predominant. In this one, it's male predominant. And in this one, it's female predominant. And then here again, it's male predominant. So no rhyme or reason. There's no biological science behind any of that. This is probably just dumb luck, and I don't think that has anything to do with the quality of the embryos, because your AB group and your AA group and your AB group are opposites of each other, and certainly from an embryological standpoint, they're not making a difference.
What kind of medications are used for egg retrieval?
Are we off of the screen now?
Mm-hmm.
Yeah, medications for egg retrieval. So do you mean at the time of the egg retrieval? We use conscious sedation, so Versed and fentanyl. If you mean what we use to get you to egg retrieval, well, there's a whole ton of medications, mostly injectable. You can use antagonists or agonists, and then you need FSH plus either LH or HCG. There's trigger shots, there's double trigger shots, so there's all sorts of things. But during the retrieval, we give you something to prevent you from being nauseated. We give you lots of stuff to keep you asleep, and we make sure our patients are super comfortable. We extremely, extremely rarely have anyone complaining about pain during the procedure. It has happened from time to time. We just give them more, and if we can't get you comfortable, we don't continue, we stop.
How long after embolization surgery should you wait to move to IVF?
After embolization surgery? Wow. So if you're having an embolization, there are complications with that, especially for IVF and for pregnancy. So if it's a uterine fibroid embolization, that's probably safer. If you're having a uterine artery embolization, that's not generally considered a great idea if you're trying to then get pregnant. But if you've just had your uterine fibroids embolized, it'll take several months for the inflammation to settle down. So you can make your embryos anytime you want, but don't try a transfer until your fibroids have stopped the process of decay and necrosis. That, at a minimum, I would think would be 2 to 3 months.
Does BMI play a role in fertility, and what are the stats?
Oh boy. So we have lots of videos on our YouTube channel. So check that out. Just go to youtube.com/drvictory. And you can see our videos there on BMI. We have several. BMI plays a huge role in infertility, both those who are too thin and those who are on the heavier side. and it can reflect a very significant negative outcome for success and complications in pregnancy. So BMI has a huge role on your success rates when you're doing fertility, naturally or with assisted reproductive technologies.
What is the best time of my cycle to get acupuncture when TTC?
You should contact either Jennifer Strong or Laura Jasmine or Mary Wong. They're all folks that work with us and do lots of acupuncture. Most places will want to start it at least several weeks in advance. And then sometimes either the day before or the day of an embryo transfer. But the majority of them believe in kind of establishing your healthy biology well in advance.
What is the likelihood of eggs maturing a few days after retrieval? Is it possible?
We can mature them in the lab, but the results are generally not good. If you mean eggs maturing in you, that's the whole basis of duostem. The results are amazing, but it takes several more days, even a week or two, to get the additional eggs to mature and then for us to get them.
I have stage 4 endo. What protocol do you recommend for my upcoming FET?
So you want to use Lupron and Letrozole for 3 months first. You should be on NAC, coenzyme Q10, and turmeric or curcumin. You should be taking lots of vitamins, and then basically use Letrozole a little bit past the Lupron effect. And then you want to go ahead and get your embryo transferred in with the minimum amount of estrogen possible. You need vaginal and injectable progesterone. Stay super healthy, keep your inflammation to an absolute minimum, and see how things work out.
Hey, Dr. V, is it okay to do an FET in the same cycle as an operative hysteroscopy?
No, not even remotely okay.
Subchronic hematoma outcomes after heartbeat seen.
Probably of minimal concern. We've got one patient with that right now. As long as you take it easy and don't do anything too crazy, you should be fine.
While doing IUI, if we are getting positive OPKs, should we still do a trigger that night?
Yes. So that's actually been shown to be beneficial. There's a study we reviewed, I think on the show or on Instagram, I can't remember right now, but that shows that even if you're naturally surging, being triggered actually improves your success rate. So we do recommend that.
What supplements do you recommend for RPL?
Supplements for RPL? Aspirin. That's the only supplement for RPL. There is no supplement for RPL. I mean, you can certainly use things that will reduce your inflammation, but aspirin's the only, and you can't really call that a supplement, a medication. I mean, we use lots of meds for RPL, but supplements for RPL, no one's even looked at that realistically. The picture of me that is currently playing on our YouTube channel is positively hideous.
It's a frozen frame. Don't worry. You look great in the real thing.
I sure hope so.
Don't worry.
Yeah.
Don't look at that. What would cause mild spotting towards the end of the IVF cycle, 2 days before retrieval?
Estrogen excess? That's a good question. Estrogen excess, or if you've released an egg, or if you're doing duostem. There could be a variety of reasons. A polyp, a fibroid, that could do it as well. Instability of your lining. So there are multiple factors. Depends on who you are and what's going on.
What should be done about dermoid on my ovary and a dominant 4 millimeter cyst, same ovary?
4 millimeter or 4 centimeter?
Centimeter.
Oh, yeah, you got to get your dermoid out. Dermoids are not safe, especially if we have to do an egg retrieval, because if they're poked, when that stuff spills into your abdomen, it causes peritonitis, which is significant inflammation. You'll be in the hospital needing emergency surgery. And anytime you're having emergency surgery, you have no idea the quality of what's getting done, because the surgeon you get won't necessarily be focused on your fertility. They're just focused on dealing with the emergency. So You must have your dermoid removed before you try any fertility therapy. That's a must.
It's like me doing it.
It'd be like Tara. He's got very skillful hands for all the technological stuff. Don't worry.
I have 2 day 7 embryos rated poorly. Is it even worth trying?
So we know that day 7 embryos at best have only about a 15% chance of success. And that's when they're genetically normal. So if they're untested, I'd probably say no. If they're poor quality and untested, I would also probably say no. There's nothing wrong with trying. It's just probably going to be of minimal value. So I guess I'd say if you can afford to do a fresh cycle of IVF, go for your fresh cycle. If you cannot afford to do a fresh cycle of IVF, then yeah, go for it. There's nothing wrong with trying.
24 weeks with twins. What can I do to prevent progression to preeclampsia?
Preeclampsia, yeah, I saw that question. Baby aspirin, keep your weight down, keep your inflammation low. That's basically it. There is nothing else you can do.
Hello, Dr. V.
Hello.
What are the safe supplements we can use right before and after FET? Best.
DHA. So that's not DHEA. That's the omega-3 fish oils. Vitamin D, baby aspirin, melatonin. Coenzyme Q10 is fine if you want to use that. No one's ever shown it's helpful or not. Your prenatal vitamin, iron. All of those are the basics. And your prenatal has to have adequate amounts of folic acid. If you're PCOS, you want to be on inositol and NAC. And if you have endo, you want to be on NAC and curcumin. So those are the ones we use for our patients, and those are the ones I would recommend.
Can you tell me anything about Clomid? I heard it helps with fertility.
Well, depending on what's wrong, Clomid can be useful, although it's kind of fallen by the wayside. So Clomid is a drug called a SERM, a selective estrogen receptor modulator. And basically what it does is it blocks your brain from realizing that you have estrogen. So your brain sends out more FSH to produce more estrogen for you. And it'll help usually make 2 or 3 eggs instead of just 1. It was originally used quite a bit in women with PCOS, where it's still useful, but it's not as good as letrozole. So that's why I've said it kind of fell by the wayside. With regards to patients that have unexplained infertility, a lot of patients get Clomid or letrozole for unexplained infertility. As I recently presented at the Canadian Fertility Show, it is completely useless. Both the Canadian Fertility and Andrology Society and American Society of Reproductive Medicine and the Royal College in the UK have stated that it is epically useless and should not be used for that purpose because it actually does not increase your chances of success. So if you have unexplained fertility, Clomid by itself is not enough. If you have PCOS, you should really be starting with letrozole. We don't use a lot of Clomid anymore unless you're combining it with insemination, where then it's useful.
Letrozole protocols estrogen prior to FET. My clinic uses estrus, and I would like letrozole.
Yeah, so use it from day 3 to 7. Don't take any estrogen. Monitor your lining. If it's getting thick enough, great. If it's not getting thick enough, add in the minimal amount of estrogen possible. We usually start with just 1 milligram of estrase, and that's all you need to do. Yeah.
FET next week and having IBSD flare. Should I postpone? What are IBS impacts on fertility?
If you're talking about irritable bowel syndrome, there's no impact on fertility. If you're talking about inflammatory bowel disease, so Crohn's or ulcerative colitis, you need to stop because the inflammation will prevent you from getting pregnant. So you would have to stop and wait till your flare has subsided. And we normally put all of our inflammatory bowel disease patients on an immune protocol. But if you have a irritable bowel, not an inflammatory bowel, then there's no impact. Don't worry about it at all. Regulate it with diet.
I already did a uterine lining biopsy last week and planning second FET next week. Is it okay?
Last week did the biopsy and next week doing the transfer? No. So if you're doing an endometrial biopsy, it's supposed to be done in the luteal phase, which is right after you've ovulated, of the preceding cycle. So, I mean, if that is what they did for you, that's great, but that sounds way too close. So I would be very concerned about doing it the way you're just mentioning. 2 weeks away from your embryo transfer is very tight, and I can't see how they would have pulled that off in your luteal phase. So I would not be doing that.
That's my advice.
That was Tarek agrees.
Yeah.
Yeah.
How long after?
We need like a little button I can push where people like sound effects. We gotta get a sound effect. We
Yeah,
can
we
get
do
a
that.
sound
We do
effect.
that.
Yeah.
How long after end laparoscopy should I give my body to naturally get pregnant?
So that's a great question. How long after you've had laparoscopy should you wait before you start looking for fertility therapy, and how long, like in other words, how long should you try naturally? So the answer to that is it's entirely reasonable to try for 3 to 6 months, depending on age and depending on what they found at the laparoscopy. So if you have severe endo, it's going to be back within 6 months to a year. So the faster you get pregnant, the better. If you have mild endo, same thing, it's still going to be back. If you don't have any endo and they didn't find anything, then it changes all the dynamics, because waiting is not going to help you any if the problem wasn't something that they could fix. So it really depends a lot on what they find on your laparoscopy. If it's endo-related laparoscopy, as you're mentioning there, then I would say that you definitely can give yourself 3 to 6 months. Beyond that, you're risking the endo coming back, and at that point, you're diminishing your chances again. So I'd get on with it at that point.
Would you recommend IVF for recurrent miscarriage?
IVF has been studied for recurrent miscarriage. It does have one benefit, and that is that we can figure out if you have genetically normal embryos. That's the only advantage to doing it in that population. So if you have genetically normal embryos and we put them in you using an immune protocol to control everything, and infectious protocol to treat any potential infections, and thrombophilia screening, and all the tests we do, all the crazy wacky stuff that we do every day to help our patients get pregnant. If you've done all of that with a genetically normal embryo and you still miscarry, you need a surrogate at that point, or at least need to start thinking about needing a surrogate. So there is an advantage to doing it, because now you have embryos ready to go and they can be put anywhere. But that's literally the only advantage you get, is the ability to determine if you're miscarrying a genetically normal embryo. And then if you are, it helps allowing you to seek other options. Otherwise, no, it's not helpful.
My lab has told me that one of my blastocysts that I have just frozen has 2 inner cell masses. Have you seen or dealt with this much? If so, what seems to be the outcome for these embryos?
I've never even heard of that before, but I would think that if by day 5 of blastulation, it's already got a split to it, that's a very high risk for having twins. So depending on when they actually pull apart, it would determine what kind of twins they are, whether they're monochorionic, monoamniotic, monochorionic, monochorionic diamniotic, or even Siamese twins. So there's a scale as far as when embryos split that indicates what the risk of becoming the various different types of embryos is.
Medicated IUI, chances of success with 3 follicles and TMS of 20 million?
Medicated IUI with 3 follicles and a TMS of 20 million, 20%, 25%, depends on your age and your health. 20-25%, that's what the studies would tell you. But it depends on a lot of factors.
How common are uterine polyps that interfere with implantation?
All uterine polyps have a substantial chance of interfering with implantation. So if you have a uterine polyp, you should not have a transfer. You need to get it taken care of first.
I'm hoping to try inner lipids at your clinic before my 3rd transfer. I've had 2 fails. Can you explain the results you've personally seen, and when and how often do you recommend doing them?
So we've been using intralipids for a long time. It does seem to improve the chances for patients. In particular, if we know they have an immune problem, then it definitely improves things. So we use it usually 5 to 10 days before the transfer, sometimes on the day of the transfer when you get a positive beta, and then every 6 weeks. I do believe in it, and there is scientific data to support it. We've reviewed that on one of our YouTube videos too, several months back, looking at immune things that can actually help you to succeed. So that's something you can check out for sure.
How often have you seen more than one problem-causing uterine bacteria present at the same time?
When we do fertility testing, if that's what you're asking about, we frequently see that there are more than one infection present. So that's very, very common. We see that all the time. Yeah.
Big one. You ready?
Born ready, baby.
All right. Went to my baseline scan yesterday.
Okay.
5 days after stopping the combined birth control pill that had been on for a total of 40 days.
Okay.
This scan showed a thin lining and no cysts, but my ovaries weren't quite enough, with a follicle of nearly 11 millimeters and one nearly at 10 millimeters. My blood test showed elevated estrogen and progesterone too. I'm 36 and have an AMH of 12.85 picomoles per liter, and AFC is 18. My clinic has put me on the combined pill for another 10 days in order to further suppress me. Why would the pill not have suppressed me enough? Will a further 10 days on the pill be enough to suppress my ovaries so that I can start stims?
Probably not 10 days, but I guess my question would be, why are they suppressing you at all? Why not just go natural? So you don't necessarily need to be suppressed for any reason, but I would definitely go on it for longer than just 10 days, because obviously it didn't work the first time. So why would they think it's going to work again? But I'd encourage you to try natural. That's probably got a better chance.
Hi, Dr. Victory.
Yep.
Do you see higher fertilization, blastulations, euploid, and live birth rates with Zymote than with centrifusion sperm sorting methods?
Not with IVF. We don't use the Zymo too much for IVF because you don't get that many sperm through it. And my embryologist feels that she can do better just choosing on her own. So we don't tend to use Zymo for IVF. With IUI, we use it quite a bit because it's a different, ball game there. But no, we're not seeing that. I think that people at Zymo have not demonstrated that either yet. So we're not seeing that yet. But it's cheap, and there's no reason not to if your center wants to use it.
Hey, Dr. V, can you explain what exactly guarantee live baby IVF process is and how much it costs at your clinic?
The process is no different than anything else. We're just guaranteeing you a baby. So if it doesn't work, we give you back almost all of your money. And the costs vary dramatically depending on what you're looking for. So if it's a live birth with your own, it's just over $20,000. If it's a live birth with donor or a surrogate, then the costs are higher. So it depends on what you are trying to achieve. But overall, our costs are very reasonable, and they're lower than everybody else's for those things. So that's what a live birth guarantee is. We're not guaranteeing you a baby. We're guaranteeing you your money back if you don't have a baby. So it works very, very well.
Wondering why you keep your patients... Oh, I can't see it. Okay, here we go. Yeah. No. Hold on. The Instagram on the desktop keeps moving. Okay. Wondering why you keep your patients on progesterone suppositories till 36 weeks. I see a lot of clinics stop all meds by 12 weeks.
Yeah, because fertility patients are at higher risk for preterm labor, and progesterone reduces the risk of preterm labor. So we keep our patients on it until 36 weeks to cut down the chance that they're going to deliver early. Can you flip to a screen share real quick? Are we still sharing?
Mm-hmm.
Yeah, we are. You got it there?
Mm-hmm.
So in the middle of the YouTube page there, this is under our popular uploads. You can see the one that's pink. It's got immune therapy there. So for those of you wondering about intralipids and stuff like that, it was covered in that video. We went through all the things that work. So if you've got recurrent pregnancy loss or you've got an immune therapy issue, read that and see what you think.
A lot of windows. Okay. Beta 149, 12 DP 5 DT, and 238, 14 DP 5 DT. Any chance of viability?
What was it the first time?
And ask beta 149, 12 DP 5 DT,
Okay.
and
the next one?
248, 14 DP 5 DT.
So yeah, that's normal. You've gone up by 60%, so it should be okay.
What about the grade number 1 to 6?
Yeah, they didn't score the grade number in that particular study. They were just looking at the morphology without looking at the number. So the degree of expansion they controlled for, obviously the more expanded your embryo is, the higher the chance of success, for sure. That's a good question.
Chance of an issue on an NIPT test with a euploid tested embryo?
Usually around 0.3%. Somewhere between 0.3 and like 1.3. It's very, very low. Very, very, very low. Possible, but very low.
What are the important questions to ask your doctor regarding an abdominal myomectomy?
How many have they done? What kind of complications have they had? How big an incision they're going to make? Do they make the incision on the uterus horizontal or vertical? If they're going vertical, they probably don't know what they're doing. How do they sew it? So the whole key with a myomectomy is that you're creating a crater. You want me to draw it? I don't think I can draw this one.
Okay.
Well, actually, you know what? Maybe I can. Hang on a second. Where's draw? Do we have draw on this thing?
In your notes?
Let me see. Yeah, probably in notes. Let me see if I can draw. Oh yeah, we've got it in notes. Okay, let's. I gotta blank this one out. Let's do a new one. Okay, so if okay, you got me there.
Mm-hmm.
So if your incision is like this, I'm making it a V because it's actually a bowl, but if it looks like a V, it's easier to understand. Some people will just take the suture and they'll run it from here to here to close everything up. That is epically useless because you're going to get a big empty space all through here, and all of that's going to fill with blood, and you're going to run into a huge amount of problems with it. So the correct way to do this is to actually take the stitches and start one layer here. Actually, let me do that in black for you guys. So you're going to take one layer here and pull that together. Then you're going to take the next layer here, and then another layer and another layer and another layer, and you keep going until you get to the top. So depending on how big it is, we will put together anywhere from about, I don't know, I'll put in 3 to 8 layers of suture. And what's happening with each one is that the bed is closing. So as you do this, your V is getting narrower and narrower and narrower until it closes at the top. And now, instead of that big empty space at the bottom, you should have something that looks like this. Yep. and your stitches are going across, so that you've closed that space where originally it started looking like this, basically. So you want it to pull right together and close up tight. That way there's much less risk of rupture. So you need to know how many layers of suture they're going to put in. Those are the major things that you would want to find out.
It's a great drawing.
Great drawing. There you go.
How often should a doctor be performing the surgery in order to be an expert? As follow-up to the myomectomy.
How often should a patient do the procedure in order to be an expert?
The doctor.
The doctor?
Yeah.
Yeah, you should be doing the procedure a lot to be an expert. So I wrote a chapter for a textbook on fibroids. I've probably done myomectomies once a week or twice a week, every week for the last 15 years. So I think I qualify for an expert status. But you know, if you're doing it like once every couple of months, you're not going to know what you're doing. Yeah.
I haven't had a natural period without Provera since going off of BC in 2019. Started metformin in December for PCOS and got my first natural period this week. Could metformin alone have done that?
Could metformin alone have made her have her natural period? Yes. There is some tendency towards more frequent ovulation on metformin alone for PCOS women. So yes, that's entirely possible.
Chances of an issue on an NIP with a euploid tested embryo?
They asked us that.
Okay.
0.3 to 1.3%. It's really low.
They're saying you forgot to discuss the number grade in conjuring to the. No, we did that.
No,
right?
we did discuss the number grade, guys. So they didn't look at the number grade because most of these embryos are going to be expanded. But the bottom line is that they were factoring the degree of expansion when they adjusted. So that's less important than the morphological score.
Doing FET first week of March.
Okay.
On Estradiol patches right now.
Sure.
Is it safe to have unprotected sex at this time? I remember hearing that exposing sperm of a partner is good before an FET.
Yeah, it's great. You should do it. And we have another video on that somewhere on our YouTube channel too. So definitely do that.
I have 6 untested embryos ranging from 3AB to 4AA, 1 day 5 and 5 day 6. What are my chances of a live birth with those numbers? I'm 36 and have 3 failed Pgta transfers.
Wow. I don't know why you failed 3 Pgta transfers. So I would need to know way more about you before I would even venture a guess as to what your chances are. Your chances are probably excellent, but only under the right circumstances. The fact that you failed 3 Pgta tested embryos means that you're in the 4.8% of patients that didn't succeed with the 3 embryos. So those patients need a lot of investigation and therapy. You should not just have another embryo transfer. It won't work. So make sure they're testing you first. Excuse me. Yeah.
Can you please explain how effective Clomid is?
Well, again, it depends on what you're using it for. If you're PCOS and you're using Clomid, you have a 17.9% chance with 6 months of use to have a live birth. If you are not PCOS, you're unexplained, it's useless. On its own, it will not help you. If you're using it for something like insemination with medication, it can be very helpful. If you're using it in conjunction with IVF, it might be helpful. So it all depends on what you're using it for.
Is vaginal dryness a side effect of estradiol?
No, it should be the opposite. Yeah, the more estrogen you take, the more lubricated your vagina should be. So you should not be having vaginal dryness on estrogen.
Hi, Dr. Victory. You're a patient here from Toronto, always watching your amazing show. How does this study affect your patients that is turning 35? Will this change the way you do their protocols?
No, so it's a great question. This doesn't actually change the way we run our protocols. This changes the way I advise patients. So would I advise a 35-year-old differently? Only if you end up with poor embryo quality for some reason, and we're looking at a C-graded embryo. But otherwise, no, because your age was the reference category. So obviously that's not an issue. And as far as the embryo grade is concerned, we'd have to wait until we actually got the embryos. We have a very holistic approach to our IVF program, so we tend to, do a really good job with covering all the bases. But we try our hardest to get, the best quality embryo we can every time.
What's the average amount of IVF frozen embryo transfers do you see before successful pregnancy?
1 or 2, we're pretty good. So usually it doesn't take us many efforts to get people pregnant. I mean, there are people that take more, but generally speaking, with us, 1 or 2 tries and they're pregnant.
Fresh transfer versus frozen embryo transfer. Which one is better?
So scientifically, there's no difference overall, although frozen embryo transfer can be more successful in some circumstances and reduces the risks of the pregnancy by and large. However, I don't believe in cookie cutter medicine, as you all know. So there are some circumstances where fresh embryo transfer makes sense. Natural cycle IVF with no complications, minimal stim with only 2 or 3 embryos being produced, with only 2 or 3 eggs being produced. Those are opportunities where a natural cycle, fresh cycle, you can definitely go ahead and do a fresh embryo transfer. But if you're doing it with, someone that's made 19 eggs or even 10 eggs, you've got supra-physiologic estrogen levels, meaning way above the normal level. In those circumstances, your body is not designed to get pregnant. And so we definitely would recommend against trying, because it is a higher risk pregnancy, and I firmly believe your chances are much, much lower.
At the age 35, how many IUI should I do before moving to IVF?
At 35, you're allowed up to 6. So you can try up to 6 times before moving to IVF, but it's personal, right? It depends on the quality of the sperm. It depends on your health, on how strong your ovaries are, what your tolerance for trying 6 times in a row is, where you're doing it, how much they're charging you. If you're somewhere where they're charging you $1,200 to do each IUI, like places in Toronto, and you're going to go through 6 cycles, you're basically getting awfully close to spending what you would for an IVF cycle, in which case it makes sense to just go straight to an IVF cycle. So it depends on the cost. We're like a quarter of that, so we don't feel bad when we're telling people to try.
Good evening.
Good evening.
How fast were your...
Was that you or the patient?
That was the patient.
Okay.
But they put the exclamation mark. I just assumed that means good evening. My assumption. How fast will your AMH drop each year? In 2019, it was 11.4 picomoles per liter, and now 7.5. Would this decrease be roughly normal?
It was what? And then now it's what?
11.4.
In what year?
2019.
Yeah.
And now 7.5.
Yeah, it's so age dependent. So if you're 20 and it's doing that, that's abnormal to begin with. But if you're like 38 and it's doing that, that would be totally normal. So it's very dependent on your age. It's a ski hill, though. It definitely drops off a cliff at a certain point. It goes down really quickly.
Hi, Dr. V. I would classify myself as a newbie when it comes to IVF.
Okay.
Little background. I had 2 ectopics in a matter of 9 months. First one treated and second one surgery, which resulted in my left tube removed. Currently on the wait list for the first funded cycle. Should be coming anytime soon.
Okay.
Was advised to take vitamin D and folic acid. Is there anything else you would recommend taking while waiting?
Coenzyme Q10, your prenatal, the omega-3 fatty acids, melatonin. We have loads of videos on this. So pretty much any one of our YouTube videos you watch, somebody has asked this question. So melatonin, vitamin D, CQ10, your prenatal vitamin, iron, all of these are important and will help you. And then other things depending on your diagnosis.
Hi, Dr. V. Is there a high probability of autism spectrum disorder with IVF? I received secondhand information that there was, but I haven't seen any research to support that.
Where age in a patient becomes the factor, age does have a role. So if you're older, you may be more prone to needing IVF, in which case your risk of autism increases just strictly based on maternal and paternal ages. So it's not the IVF, it's the age that's the factor, but just purely IVF, no.
What is a typical time frame between IUI cycles, i.e. consecutive months, every other month, etc.? Can a patient request which months for an IUI cycle?
Yep, that's totally up to you. Yeah.
Could you explain what dual trigger is and when you would suggest to put that into a patient's protocol?
So we dual trigger everybody, and it's a combination of a gonadotropin releasing hormone agonist like Lupron with HCG. And there are multiple studies that show that it's beneficial. So we do it for all of our patients. More mature follicles, better fertilization, better blastocyst.
Loss from high-grade fetal vascular malperfusion.
Loss from?
Yes.
Okay.
How likely will it happen again? Is there anything you can do to prevent? Is there any way for treatment to manage?
I would need to know more about your history. I mean, it's impossible to answer that without more details. Certainly aspirin, heparin, those kinds of things we would want to look at. Placental well-being, your social habits. Are you a smoker? Your body mass index, sugar control if you're diabetic. All of that stuff would be hugely important. So I need to know a lot more about you. You should probably contact info@drvictory.com and we will get in touch with you.
How soon after you have completed your antibiotic treatment for endometriosis can you do your
for endometritis or endometriosis?
Endometritis.
Yeah.
Can you do your FET? Do you retest for fertility before you do an FET?
We retest. So it usually takes at least a month or two because we retest you to make sure we've cleared it. Yeah.
Ready?
Ready.
Okay. My clinic unthawed the wrong embryo on the day of our transfer. I caught the error as they thought our third best instead of our best. In Canada, it is illegal to disclose gender, so our clinic puts your best in first and so on. I'm rattled that the clinic's control were so poor that this could happen. There was a lab mix-up and they confused me with someone else who requested a certain embryo. How upset or concerned should I be with their competency?
Wow. Well, human error happens. So I'm not going to tell you in any lab anywhere that they've never had a problem because everybody has because they're human. I mean, that's just the way it goes. If they didn't put somebody else's embryo in you and they only thawed not your best embryo, I would just insist that they do it for free. But aside from that, I wouldn't be concerned necessarily unless this is a pattern and you've seen it from other places, other people at the same institution. Otherwise, I mean, I would be saying, look, I clearly asked for embryo, 1 and you gave me embryo 3. And because you're putting in the wrong embryo, I want this done for free. And I think you're justified to ask for that. In fact, we would have done that automatically. Yeah.
This question sitting here. Hard to read.
It's 9:00. Is there a lot of questions?
I don't think you're done, man. What's your recommendation for the amount of CoQ10 per day?
600.
Nice one.
That was a gimme.
See, getting through them. Loss from high-grade fetal vascular malperfusion. Good. She went on YouTube and on Instagram. She tricked me. How many days before an FET should interlipids be done?
We reviewed that earlier, but 5 to 10 days before, on the day of, and then when you get a positive beta, and then every 6 weeks.
A lot of numbers. You ready?
Yeah.
TNF 54, INF 34, NKCD 19,
Okay.
28 RE.
Okay.
Recommended 25 milligrams of prednisone 1 month before FET and 2 pens of Humira before FET. What else do you recommend as I want this transfer to be successful? Thank you.
I'd suggest you see a reproductive immunologist who really knows that field. So we use tacrolimus and sirolimus, intralipid subcutaneous IG therapy. The steroids are reasonable. Intralipids, there's all sorts of stuff we use. So it's not just one thing. You should really see a reproductive immunologist.
How long should I wait after beginning subcutaneous IG to try for pregnancy?
A month.
Love these answers.
I love the quickies. Yeah.
Hey, Dr. V.
I mean, that's strictly in relation to your question.
Absolutely. This is a professional place here. Do you recommend intralipid IV infusions for someone with Hashimoto's on lavoxarine? For someone, yeah.
I would if you've had multiple miscarriages or trouble getting pregnant with IVF. Otherwise, no. But yes, if you have high antibody levels, you've tried the supplements like selenium and inositol, we can't get your antibody levels down with your thyroxine level up and so on. Yeah, I would think that that's very reasonable to consider.
How many rounds of frozen embryo transfers are common before a positive pregnancy with Pgta tested embryos at the age of 30?
1, maximum 2. At the age of 30, your embryo quality and your age are both excellent. So as long as there's nothing I'm missing in the whole scheme of things about you, because I don't know anything about you, your chances should be outstanding. We would anticipate 1 transfer with us would give you about a 70 to 80% success rate at that age, especially with a euploid embryo. 2 would probably be getting you over 90. 3 should basically be getting you as close to 100% as possible.
Would a small follicle on an ultrasound affect ovulation?
I'm not sure I understand that question. A small follicle will not affect ovulation. It has to get big enough in order to produce enough estrogen in order to get the brain to send the signal for ovulation. So I'm missing something you're asking there. Sorry.
Hi, Dr. V and T.
And T, we got finally got a T.
I was waiting all day for this one. Can you explain why Neupogen is helpful for adenomyosis patients before a transfer? I was told it helps to make the uterus sticky.
That is a fabulous question. And I have never seen anybody say that Neupogen is good for adenomyosis patients. So adenomyosis is like endometriosis, but in your uterus. So it's when the cells from the lining of your uterus invade into the wall of the uterus, and it makes the uterus very inflamed and kind of hot and bothered and irritated and uncomfortable. So Neupogen, which is GM-CSF, is an immune mediator, and it shouldn't have any impact on that. But you know what? I'm going to look that up. GM-CSF and adenomyosis. Let's see. Oh, there is one study from almost exactly 20 years ago. And it says that the GM-CSF may actually increase the level of activated macrophages in women with adenomyosis. That's very interesting. I am not aware of anybody ever that has looked at that. So I'm not quite sure what your study or what your center is thinking, but I don't think there's anywhere that has any data that suggests that that's helpful at all. You need Lupron and Letrozole to control your adenomyosis not GM-CSF.
You ready?
I'm ready. I'm
Dr.
still
V-
full from dinner, man. We ate so much sushi.
Yeah, we did. I got rice coming out of my ears. Dr. V and Tarek.
And another tea. Thank you for including Tarek, guys. He was feeling a little disgruntled and disheartened over here next to me.
Got to keep my straight face on. I'm feeling discouraged that this is taking a while to clear up my urea plasma.
Oh.
Is it typical to have a stubborn case that takes a 30-day course of antibiotics? What could be the cause if it's still present after my next recheck?
So urea plasma is very difficult to get rid of sometimes because it can be very resistant. Make sure they're treating your partner as well, because that can be something that gets missed frequently and causes a problem. So, oh, excuse me, sneeze. So yeah, that would be the major factor. Check your partner. You may need multiple antibiotics in order to get rid of it.
Hi, Dr. V and T.
And T, everybody's pouring it in now. Thank you for the love, guys. We don't want to forget T.
Is a 3D SIS scan enough to detect uterine scarring, even if it's mild scarring?
Yep, absolutely. If done properly, we can see it.
To get a second opinion at your clinic, do you need a referral for consultation, and how long does your wait time?
You do need a referral if you're in Ontario, unless you want to go straight to IVF, in which case you can just pay for that because that's allowed. And wait time depends on the urgency of your case. So we triage people based on how urgent it is. The wait time is not very long because if it's basic, we have another doctor working with us. She takes on the basic stuff and it gets to me if it's more complicated. But they all end up being reviewed by me anyways. So I kind of oversee the whole program. If it's complicated, yeah, I'll get you in relatively quickly.
Just wanted to say thank you for being the best doctor ever.
Oh, thank you.
See,
that's very sweet.
Not everything's got a T in it, you know.
Not
Sometimes it's just you.
And the best web guy and media guy ever. Yeah.
Thank you for answering my questions, Dr. V.
Oh, my pleasure. Thank you guys for watching.
Priming and estrus, testosterone, and progesterone for IVF.
Dude, you're just going to keep going?
It's the last one after this.
Oh, so
that's why I see the end. I see it.
Okay, you see the end.
Yeah.
Go for it.
Can we still try naturally this cycle?
Priming what? What was the question?
Priming and estrus.
You can do estrase priming and then try naturally. Sure. Yeah, there's no reason why you can't do that.
Last question.
Last question.
Yeah.
Okay.
When should you be considered for intralipid When should you be considered for intralipid infusion therapy?
Oh boy. So if you have an immune problem and we've tested you, for sure. Random unexplained failures, considerable. Recurrent pregnancy loss, I'm a believer. Known immune problem, that's reasonable as well. So if you have like a Wagner's or a arthritis or Crohn's disease or something like that, those are all reasonable instances too. So those would be the major times that we look at it.
One just popped up. You want me to? You looked at?
They're endless, man.
Yeah, I know.
Okay, last one.
Last one.
Like the absolute last one.
Big one.
Oh, great. Of course.
Dr. Victory! Exclamation mark. That's why. Yes, she got lucky. I actually read it. I'll be honest. I'm 33 years old with unexplained infertility.
Okay.
We did our first FET in January, which resulted in a chemical pregnancy.
Oh.
I had been treated for mild endometritis in October.
Okay.
My repeat biopsy returned clear before my first FET. My RE wanted to do another uterine lining biopsy before we transfer our next embryo. She said it's to confirm no infection caused by chemical pregnancy and that lining is still clear. I've had the biopsy and I'm waiting results. If clear, plan is to transfer embryo within 2 weeks of biopsy. Is this essentially a scratch? And should I be proceeding with transfer so close to a biopsy? Was this third biopsy necessary? Thank you.
So I don't do biopsies because actually they're useless. So if you're going to test for infection or endometritis, you have to do it with a PCR test to search for bacteria, which is Emma analysis or Fertility or one of these sophisticated tests. we don't do biopsies. So yes, you are getting a scratch. As I've often said on the show, this endometrial scratch is literally the most controversial thing in all of infertility. In fact, we started fertility factor fiction with the endometrial scratch because we were talking about that. So that was our very first episode. And it still to this day has studies that go back and forth as to whether or not it's valuable or not. I think there was another new one just last month again. So, and it said it wasn't valuable. So we don't do scratches. We just go straight to doing the actual endometrial testing. And that gives us a much better answer. Can you get a transfer within 2 weeks? No, you should not do that. For sure, don't do that. Okay, guys, that was an extra long edition of Fertility Factor Fiction. Thank you all for joining us. We love you guys. Make sure you join us on the show every week. We're usually Monday or Tuesday nights at 8 o'clock. And jump on our YouTube channel, which seems to be growing leaps and bounds, and sign up for a subscription and hit the notifications button. So every time we do one of these cool videos, you'll find out. Have a great night. And